Okay, so welcome everybody. We're on workshop 4, so the second last workshop. And today I thought we could go through some data analysis um, slides and look at what your findings potentially can look like. We all know what the subject's about now. You've got your subject learning outcomes. Everyone's done assessment 1, and that's all marked. And then assessment 2 is your next one. So that's due in 2 weeks today, actually, this afternoon. And that's worth 30%. I'll just go through those. The video pitch assessment and rubric. So yeah, so it's worth 30%. It's sort of between 3 to 5 minutes. Or individual assessment. It's just you talking to the screen, to the camera. No PowerPoint slides or prompts or anything. And the idea is for me to see you and hear you talk about your project and explain it sort of in layman's terms. So the idea is that imagine you're on an elevator, you get in at the first floor, and it'll take 5 minutes to reach your desired level of the building. And the person next to you, without any clinical or research experience, asks what your project is about or what you're working on, and you've got those 5 minutes to describe your project in general terms. And I'm looking at subject learning outcomes 3 to 5. With the rubric, there's only 3 criteria that I'm marking. So alignment is worth 40%, and that's where I want to, I'll be looking at whether there's a clear articulation between, talking to me about your project being on an important, relevant problem from a practice point of view, and that the project design and project outcomes align to that problem statement that you're talking to me about. So I'll be looking for a clear statement on the importance and relevance of the problem, insightful and interesting connections made between how the project design aligns to the problem and how the outcomes will inform resolving the problem in practice. I'll then be looking at synthesis, so that's worth 30%. So I want you to highlight the key points of the project to convey the project to me as a general audience. So I'd be looking to see that you've synthesized the key points of the project with exceptional clarity. So this is all the high distinction marking criteria. With exception clarity, that's easy to follow and understand and uses language appropriate to a general audience. And then pace, presentation, and language is worth 30%. So just want you to hold the attention of the audience by maintaining eye contact. That's obviously just looking at the screen or the camera. Speak clearly and fluently, and speak at a steady pace. So would want to see a high distinction, would see that you're highly skilled in holding the attention of the audience, maintaining eye contact throughout, and speaking with expression clearly and fluently and at a steady pace. So does anyone have any questions about that one before we go on? Okay, I'm just going to go back a few slides. Just always important to say the academic integrity one, making sure you know what you can and can't do with Gen AI. We do allow its use at UOW. Just make sure you know the policy and how you can use it. And then with assessment 1 feedback, I was just going to go over that sort of high level summary. So well done, everybody. Overall, everyone did really well. And my main points for you to use in your final report was that a lot of people were using US spelling with Z's instead of S's, which can happen if you are using Gen AI to, do any checking clarity or anything like that of your writing, which again is fine, it's allowed, but just make sure you use Australian or British spelling with the S. For the people who are doing the integrative reviews, I just wanted them to go back to look at some of the resources I provided on how to do them. So these were for the people who are not working clinically and not doing a project. And also highlighting that the review had to be novel. So some people were doing projects, or their ideas were around things that already had some sort of systematic review, integrative review, narrative review on a topic in the last 5 years, and that would make it really difficult for them to provide an original contribution. in that assignment. So they were my tips for people doing interview reviews. And then with the QI projects, they were all done really well across the board generally. But the strongest proposals came from those with a clear and straightforward project idea. So simple projects are usually the most effective, and there's no need to overcomplicate your approach. So just focus on clarity and feasibility. And then also with expression, just making sure if I've made any comments about expression or language, just take extra care to explain your ideas clearly and write concisely in your final report. With writing, I think a good tip, or what I tell people with PhD students and other people that I'm teaching how to write academically, is that you've got to get what's in your head in my head. And the only way you can do that is through written word. So you need to be clear, and it doesn't matter if it makes sense to you, it's got to make sense to the person reading it. So whenever you're looking at things, think about whether it would make sense to someone else reading it coming from outside. Does anyone have any questions about that?
Gemma, sorry, I have a question, but it's more about back on assessment 2.
Yeah.
But it does relate to this as well. Now, when you've asked for the link to be uploaded for that video,
Oh, yes.
do you also want the reference list submitted through there, a reference of the information, or is that not applicable?
No, you don't. No, you don't have to, because yeah, I haven't made references a part of the rubric, so I won't be marking those.
Okay, so
I
purely
mean, if
just
you
the
wanted
link
to,
for the
if you,
upload.
yeah. If you're so inclined to be very thorough, you're welcome to. But with the marking criteria, there was no. I'm not marking references. So
Okay, thank you.
that's okay. Anyone else? No. Okay. So wanted to make sure, are all of you going to use Excel to collect your data? And do you all have the data analysis function enabled? You do. James is nodding, looks like. Trin, do you?
I'm checking now. I'm not sure.
Yeah. So it's just that making sure you have that plug in there, that the little button there. Anyway, it's fine if you don't, because you can, it's easy to set up. I've put the instructions there on the slide so you can go back and look later in how to add it in. In some ways you don't necessarily need it, but I think it's handy to have anyway in general. So I do recommend that you get it. Have many of you done stats before? Sorry, now I've lost you. Where have you gone? There you are. Yeah. I'm sorry, I can't see you anymore. So if you'll have to, this is so stupid. Okay, sorry. I can't see you, so if you have any questions or want to stop me, just you'll have to take yourself off mute. So I'm going to just do a sort of whistle-stop tour of data. Again, I'm not sure of your backgrounds and if you've done data analysis or statistics subjects before as a part of this degree or previously in any other way. So I'm just going to sort of provide some sort of background, essentially basic information about statistical analysis and data. But note when I'm going through this, you don't need to do all of these things for your project. Many of you won't have a big enough sample size to be able to do any kind of inferential statistics. So you'll purely be presenting frequencies, things like that, just very descriptive statistics. And I've got 2 examples at the end of previous assignments to show you how they did it. But first things first, we always have to, when you're looking at doing data analysis and statistics and things, we first have to think about, you've got to identify the types and level of quantitative data that you have. And the reason that I'm saying quantitative data is because I'm just purely talking about numbers. However, I have written here with the 2 types of data, you have qualitative data or quantitative data. And if you have done any kind of analysis or other research before, you'll know that qualitative data can mean is actually more about getting words, doing interviews and focus groups, not associated with data analysis in a quant way. But there are 2 types of quantitative data, and they are qualitative data or quantitative data. So qualitative quant data is descriptive information that can be categorized, but not measured numerically. So it can be nominal data. So that's things like gender or blood type, or it can be ordinal data. So education level. So, you'd be high school, college, university, things like that, or on a pain scale. So on a Likert type, from 0 pain to 10, that kind of thing. And then quantitative data is that, like, typical of it, as we know, that numerical data that can be measured. So, and it can be discrete. So number of children, so I've got 2 children, number of hospital admissions, that can be, you could have 10 hospital admissions or 2. You can't really have 2.4 hospital admissions, or continuous data, which should be things like height, weight, blood pressure, and that's where it's measured on a continuous scale. Yeah, so it's continuous data. So you've got your types of data, and then you've got levels of data. And the levels of data, again, if you've done any sort of reading or done this before, you've got nominal, ordinal, interval, and ratio data. And that they're almost like a hierarchy. So the higher up you go in those levels, the more you can do with your data. So nominal data is sort of the basic type. So that's categories without order. So for example, types of dementia, and it could be the gender of patients. So there's no way of putting these things in an order. So that's nominal data. Ordinal data, ordered categories, but the intervals or the distance between them is not necessarily equal. So that could be the stages of dementia from mild, moderate, or severe, or Likert scale responses. And that, if you were using a quality of life scale or something like that, that is typically considered ordinal data, where you're saying, where someone's very satisfied or to not satisfied at all. Interval data is ordered data with equal intervals, but there's no true 0 point. So cognitive test scores are things like this, and that's a mistake. And then or depression scale scores, things like that. And then ratio data is the highest level of data that you can have, that you can do the most with, and that's ordered equal interval with a true 0 point. So age of dementia, or duration of symptoms in years or months, things like that. So that's just, if you're going to do quantitative analysis, you need to know what type of data you have and what level it is. So your variables, what are they? They're characteristics or attributes that can be measured, and they vary among individuals over time. And they're independent variables, so your predictor variables. And these are the factors that we manipulate or they're selected by researchers to test, and they're hypothesized to influence the outcome. So that can be things like age or genetic factors or intervention type. So I recently did a study on whether nurses or on nurses' decision making around performing CPR in people who have no signs of life. So my outcome variable was, do they perform full CPR, or would they call the medical team to report a death? And then I looked at my predictors were around their years of experience, their age, the specialty that they worked in, things like that. So they're your predictor variables are the things that you're testing. And then your dependent variables are your outcome variables. So they're the factors that are measured and expected to change in response to independent variables. And they are the main focus of the study. So my study was about, do nurses, when presented with somebody without signs of life, how do they make decisions around whether to perform CPR or not in the absence of a do not resuscitate order? In your studies, how this relates to you, you'll really only be looking at outcome variables. I don't think many of you would have enough data to do an analysis where you're looking at predictors. If you do and if you want to, that's fine. But mostly you'll just be looking at your outcome data. And they're just an example study. I've already been talking about my CPR one, but the effect of exercise on cognitive function in Alzheimer's disease, the independent variable that the researchers looked at in this study was their exercise regime. So what type of exercise were people with Alzheimer's doing? How often were they doing it, and for how long? And then the dependent variable was they looked at, did exercise have any impact on the cognitive function scores? And they tested that using this standardized survey, the MMSE. This is a table that shows descriptive and inferential statistics. So your descriptive statistics, so if you're looking in that descriptive statistics column, this is really what I want to see in your reports. And then the inferential statistics are, if you had plenty of data, you could do that, but they're more the things that you see in full research studies or full QI projects. So descriptive statistics summarize and describe the data. It's when you are reporting the mean, median, mode, the range, and standard deviation, so the sort of central tendencies of the data. The examples are the average onset of different types of dementia, average age, sorry, and then or the distribution of cognitive test scores in a patient group. And when do you use descriptive statistics? You use them to summarize patient characteristics, report initial findings, and identifying patterns or trends in the data. But inferential statistics are those more in-depth statistics where you're calculating p-values, choosing which tests you need to do and calculating p-values and being able to make statements about whether your findings are statistically significant. So the definition of inferential statistics is that you use them when you want to draw conclusions about populations based on sample data. And the key concepts are it's around that hypothesis testing and getting confidence intervals and the probability value. So the p-values, an example is estimating the prevalence of dementia in a population or testing the effectiveness of a new cognitive intervention. And you use these when you want to make those predictions about larger populations, or you want to test a hypothesis, or you're comparing outcomes between different groups. We don't need to go through this table, but this book here, the data analysis, the Handbook of Research in Health and Social Sciences. If you're interested in research and things, or do a data analysis, I highly recommend this book. I don't know if I've still got it open. Let me check. Yeah. So this is the book, and it's free. You can download it. You can get it through the uni, and you can download it. And it's just there's over 127 different chapters all about research methods in health and social sciences. So I think it's a really handy book to have access to if you're interested in doing more after you've finished this subject and project. But yeah, this is a table that just tells us the types of analysis that we can do based on what data we have, the level of measurement, and what our research question is. Key terms that you need to know about when you're doing data analysis. So the population is the entire group being studied. So that could be, an example is that all individuals with Alzheimer's in the UK. The sample is the subset of the population used to draw conclusions. So that could be 500 Alzheimer's patients recruited for a clinical trial. Parameters are the numerical characteristics of a population. So in this example, I've got it gives you the true prevalence of dementia in adults over 65. Statistics are the estimates of the parameters based on sample data, and estimated dementia prevalence from a survey of 10,000 adults is an example. Probability is the likelihood of an event in occurring. An example of that is what is your chance of developing dementia given certain risk factors. The significance level is the threshold for determining statistical significance. So typically that is set at 0.05. So a p-value of 0.05 indicates that a significant difference in cognitive scores, that there is a significant difference in cognitive scores between treatment groups. And then the effect size is the magnitude of the difference between groups. So Cohen's d is a particular type of test. Statistical test, a Cohen's d of 0.8 suggests a large effect of an intervention on memory performance. Hypothesis testing, what is it? It's a statistical method for making inferences about a population based on sampled data. And the key components are that we have a null hypothesis, and that's the null hypothesis is where there is no effect or no difference exists between groups, and your alternative hypothesis is where you believe an effect does exist or a difference does exist. You need a significance level. So like I said, it's typically set at 0.05, and we need to calculate the p-value, and that's the probability of obtaining the results as extreme as observed, assuming that the null hypothesis is true. Steps in hypothesis testing. So you state your hypothesis, choose your significance level, which is generally always at 0.05, collect and analyze your data, calculate your test statistic and p-value. So you go find one of those tables that I showed that tells you the type of statistical test to do based on the data that you have. And then you perform that test and you get a p-value, and then you make a decision to reject or fail to reject, the null hypothesis. So as an example, research questions like, does a new cognitive training program improve memory in Alzheimer's patients? The null hypothesis would be that the program has no effect on memory scores. And the alternate hypothesis is the program does work, that it does improve memory scores. So if your p-value comes out to be less than 0.05, so significant, you reject the null hypothesis and conclude that the program likely has an effect. And an interpretation, just a word of caution, is rejecting the null hypothesis doesn't prove the alternate hypothesis. It just suggests evidence against the null hypothesis. So we never truly prove something. We can just say that it was statistically significant and therefore likely. And another word of caution is around the interpretation of significance. So we need to consider the clinical significance alongside statistical significance. So we can run tests and prove that things are statistically different, but we need to think about whether that actually has any meaningful relevance to what we do or to clinical practice. Common statistics that you'll see in papers. This is just a smaller summarized paper. So we know that descriptive statistics summarize and describe the data, whereas inferential statistics draw conclusions about populations on sample data, key concepts. With descriptive statistics, and like in your project, you'll do mean, median, mode, range, variance, potential variance, and standard deviation. But if you were doing hypothesis testing, you'd look at confidence intervals, effect size, and p-values. And just another example there. So the average age of onset for different types of dementia, you do descriptive statistics for, or if you wanted to look at the distribution of cognitive test scores. But if you wanted to do inferential statistics, you could do things like estimate the prevalence of dementia in a population or testing the effectiveness of an intervention. And you do that through odds ratios and relative risk tests, which are other tests that you do to get those results. Just going over central tendency and measures of dispersion. So central tendency is all about mean, median, mode. So the mean or average is the indication of the center of the data, the set of data points, and it's calculated as the sum of a set of observations divided by the number of observations. The median is the midpoint and the middle result when all your data values are put in sequential order. And mode is the most frequently occurring value or category. With measures of dispersion, standard deviation is what we look at there, and that describes the spread of the data around the mean and indicates variability within the data set. So they're the types of things we'll do for your project. Odds ratio. Odds and odds ratio. So odds are the likelihood of an event occurring compared to it not occurring. An example is the odds of developing dementia in a specific age group. And then the odds ratio is a measure of association between an exposure and an outcome. So you calculate the ratio of the odds of the event in the exposed group to the odds in the non-exposed group. And odds ratios are measured on a scale from 0 to 1. Oh, sorry. No, these aren't 0 to 1. These ones are when your odds ratio is 1, it means that there's no association. If your odds ratio is more than 1, you've got a higher odds of the event occurring with the exposure. And if your odds ratio is less than 1, there's lower odds of the event occurring with exposure. An example is studying the effect of a new drug on dementia risk. If the result was an odds ratio of 1.5, it suggests that there's a 50% higher odds of reduced symptoms with using the new drug. Significance, statistical significance and p-values. P-values are reported in almost every published paper involving statistics. And this is a number between 0 and 1, which indicates the probability that an observed difference could have occurred by chance. The convention is to accept an observed difference as real if the likelihood that it is due to chance is less than 1 in 20. So that is when the p-value is less than 0.05. If this is the case, then the null hypothesis will be rejected and is said to be a statistically significant result. So there, just on that scale, 0 is looking at, 0 tells us that it was impossible that any kind of change happened by chance, whereas a score of 1 would be that it's absolutely certain that it was by chance, so it's not significant. And then there is also just sort of key there of how we can interpret or think about p-values. So a p-value of 0.25 is that it's fairly likely. There was a 1 in 4 chance that it would happen. a 0.05 is that it was fairly unlikely, a 1 in 20 chance, or a p-value of 0.01 is that it was very unlikely. So there's a 1 in 100 chance that whatever it is we're testing happened by chance. 0.01, we do drop the significance value, the p-value from 0.01 to 0.05, usually when we've got really, really, really big sample sizes, to make sure that it's a valid, provides a more robust test or interpretation. Sorry. Just going back to that point about statistical significance and practical or clinical significance. So sometimes results may be statistically significant, but not practically or clinically significant. Given a sufficiently large sample size, it's always possible to show that there is a statistically significant difference between two means being compared. However, it's important to know whether the difference is observed, that if a difference observed is one that matters. Yeah, so it's just something you always have to consider when you're looking at data. What statistics should be presented and when? So first of all, it's important to know that deciding which statistical test to use depends on a range of factors. So types of data, do you have, going back to those types and the levels, do you have categorical, do you have continuous, whether the data are paired or unpaired. And so that's, paired data is when you're looking, in our cases, like with the project you're doing pre and post, paired data would be where you have an individual's test scores pre and an individual's test score post. So you know what their pre and their post scores are. Some of you might not be collecting data in the way that you'd know that it was so like I'm just going to say off the top of my head. So if you were getting nurses to, you were testing their, I don't know, pre-intervention knowledge of pressure area care, and then you were testing it post. Paired data is when you know that it's that same nurse that completed that test with and got that score. And unpaired data is where they're not paired. You've just sort of grouped all your pre-nurse scores together and all your post nurse scores together. So that's unpaired. So it means you do a different test. And then you also have to consider whether the data are normally distributed. So that is, are they in that bell curve? This is very complex and it's outside the scope of this subject. However, if you're interested, you can read the paper that I've got there, and I can put that on Moodle. So it's there's a whole series of papers on statistics, and this one is about interpreting the results of statistical tests. Does anyone have any questions? Oh, Erin. Okay. That's Erin. Does anyone have any questions about that one? No. You're excited about your findings section. Okay. I can't remember, I'm sorry, who just joined. But I just went through sort of a whistle-stop tour of stats. But just to clarify, you don't necessarily need to do the things that I was talking about there. You really are going to just be doing descriptive statistics. The reason that you would do more, do inferential statistics is if you wanted to try and publish your project afterward or wanted to develop it further. Yes, James.
Hi, Gemma. Yeah, my question was around sort of how we structure the reporting of it.
Yep.
in our report.
Yeah.
I think you'll probably get to anyway, but yeah, that's what I'm thinking at the
Yeah,
moment.
yeah. Yep. No problem. Make sure there's no one else in the waiting room. No. Okay. Yes. So exactly, James, I'm going to go through two examples now from previous years' assignments. And I think they've done it differently, but they both these are high distinction assignments. So it really is up to what would work for how you've done your project. I will show you what these people have. This waiting room thing is such a pain.
Yeah, it was me that came in late. I was there for 20 minutes.
No.
But that's okay. I can follow on and then I'll just watch the recording from the first bit. So that's all fine.
Sorry, Crystal, I can't
That's
see.
okay. I was about 5 minutes late, so it was my fault.
Oh, no. Okay. Well,
Sorry, yes, well, sorry. I'm trying from 6:35 onwards. I can't get in. Sorry.
oh no. Oh, that's okay. We're recording, so you'll be able to
Okay.
have a look
My
later.
camera for some reason as well. Let me check.
Okay, yeah. If anyone does see anyone or any questions pop up in the chat, I can't see it when I'm sharing my screen. So please just take yourself off mute and let me know. Okay. All right, I'll go through these examples. It looks like Tara's still trying to connect with audio. Okay. Am I? Okay. Right. I think I'm sharing the right screen. Yeah, thanks, Trin. I can see you now. Okay. Yes, so what about your main findings? What are they going to look like? I've got two examples for you. So, the example number one was a unnamed hospital. Their project title was Unnamed Hospital, Inpatient End of Life Care. Sorry, I can't see my thing. Care Quality Improvement Project. And the aim of this person's project was to establish a standardized end-of-life pathway to enhance the palliative care quality in their hospital's inpatient wards through the implementation of a structured end-of-life pathway form and comfort care observation chart in accordance with the National Palliative Care Standards. And the methods that they used, as many of you are, were pre-test and post-test quality improvement designs over the past, they looked over a 4-month period across the geriatric, general medicine and renal wards, and that approach allowed for a comprehensive assessment of the measurable outcomes of care provided and the subjective experience of those involved. The main findings, so this is how they set out their report. Their main findings are that the main findings from their quality improvement project demonstrate significant improvements across several key domains of end-of-life care delivery, supported by quantitative evidence from pre- and post-implementation assessments. So they've provided a summary of the results. The end-of-life care intervention led to significant improvements in multiple aspects of care, as shown by the pre- and post-intervention assessment on a 5-point Likert scale, with the ratings ranging from 1 to 5. So 1 was very poor, and 5 was great, was the best score. Right, I saw a chat. Someone was in the waiting room. Yeah. So with ratings range from 1 to 5, with an additional unsure option, they've scored at 0.05. Data, they got 64 participants showed a positive change across several domains supporting the intervention's effectiveness. And then they split up their results in with how their pre and post test survey worked. So confidence was one sort of domain. So they've summarized that. So in their confidence paragraph, they have one of the most notable improvements in healthcare providers' confidence in delivering was in their confidence in delivering end-of-life care. So before the intervention, only 63% of providers reported moderate to high confidence. And following the intervention, this number rose from 88%, with average confidence scores increasing from 2.8 to 3.3. And importantly, the percentage of practitioners who identified as very confident increased from 28.13 to 46.88, while those feeling not so confident decreased from 69.69 to 12.5. Communication and decision making was the next domain that the survey they used looked at. So communication between healthcare providers and families also showed considerable improvement. The effectiveness of family communication increased with average scores from 3.2 to 4, moving positive responses from 53% to 77%. And in addition, documentation for interprofessional communication and family communication improved, with mean scores rising from 2.1 to 2.6 to 3.9, and from 2.5 to 3.9 respectively. The intervention also had a significant effect on patient-centered care, especially in terms of respecting the wishes of patients and their families. This domain showed the largest effect size, with mean scores increasing from 2.88 to 4.03, favourable responses from 34% to 77%. Cultural support from patients also improved, with mean scores increasing from 2.9 to 3.9, reflecting an increase in positive responses from 38% to 72%. And family support following a patient's death also saw improvement, with mean scores increasing from 2.9 to 3.8 and positive ratings rising from 39% to 72%. Clinical care management was the next domain looked at. So in clinical care management, comfort care transitions and planning improved significantly. The timeliness of comfort care transitions saw notable improvements, with mean scores jumping from 1.9 to 4 and increasing positive responses from 14% to 80%. Comfort care planning and documentation also improved, with mean scores increasing from 2.6 to 4.1, while specialist referral coordination grew from an average of 2.9 to 3.9. So we can really see that whatever the intervention was that they implemented had a positive effect. Symptom management was the next domain. So symptom management in areas such as pain, nausea, secretion, and anxiety also showed improvement. Pain management scores, for example, rose from an average of 3.53 to 4.2, with positive ratings increasing from 67 to 91%. Nausea management saw similar gains, with mean scores rising from 3.5 to 4.0 and positive responses growing from 63 to 84%. Secretion management scores went from 3.3 to 3.9, while anxiety management scores increased from 3.3 to 4.0, reflecting a rise in positive responses from 64% to 84%. Documentation and support. Environmental and supportive care improvements were also evident, and the provision of a comfortable environment improved, with scores rising from 5.2 to 3.7 and positive ratings increasing from 23 to 67. Food and fluid management for comfort similarly improved, with mean scores going from 3.4 to 4.2 and positive ratings increasing from 56 to 88%. Sorry, I just saw a... Oh, so Erin, I've just seen your message. When we've finished this bit, we can go back to, we can talk about that presentation. And then this is just so yeah, essentially in your main findings in your report, I really want to see this type of summary, and you can give me the numbers in this way where it's sort of, you know, in paragraph sort of story form. And then in your appendices, you will have you can put your data. So this person, this was the so they've got their demographics, as in they had 59 nurses complete the pre-survey, 3 senior nurses and 2 enrolled nurses, and then post-survey they had 61 nurses, 2 senior nurses and 1 enrolled nurse. If you wanted to do inferential statistics for this, we'd have to say that this was unpaired data because these numbers are different. There's clearly different people that have completed the pre and post surveys. And then, so these were the questions within the survey for the pre and post. So things like how confident are you in knowing when end of life care should be commenced. And then they've got the scores. So the sorry, they've got 1 to 4 there, and then 1 to 4 down below, 1 to 5 down below. But anyway, so with a score, if a nurse or if a healthcare professional scored 1, then it says that they are uneasy, and if they scored 4, then they're very confident. So then they've calculated the percentages of each score, and we've got pre and post. And then they've also done a bar chart. So it's a really good idea to do a bar chart. And here we can see the light blue is the post survey, and the dark blue is the pre survey. So oh no, sorry, that's the other way around. Don't know why they've got 3 colors, but I would assume, I think they've actually got that wrong, because you would expect to see the post survey confidence lines improve between pre and post. So then the next question, overall, how well does the hospital provide care of the dying adult patient in general wards? We've got the scores from 1, very poor, to great, which is 5, and then their percentages, pre and post, and again, they've got those the bar chart. And then they also had, at the very end, they had the raw data side by side. So I've only got the example of the first question here, but how confident are you in knowing when end of life care should commence? So with the pre-survey, we know it says that 5 people said that they were uneasy, so that was 7.2%. But the post-survey, 0 people reported that they were uneasy. And they've just got they calculated the mean scores for everything for pre, and the mean scores for post, and the frequency, the change in frequency, and then what the improvement was. So it was a 25% improvement in people's confidence. So you can also include that type of table in your appendix. Does anyone have any questions about that example, or I can show you the next one? All right. So example number 2 was on knowledge of nurses in preventing pressure ulcer in residents with spinal cord injury. The aim of their quality improvement project was to intended to lower the frequency of pressure ulcers among residents with spinal cord injuries by increasing nurses' awareness of pressure ulcer preventive measures through educational intervention is what they did. They also used pre-test, post-test audit using a standardized tool known as the pressure ulcer knowledge assessment tool. And again, this is the main findings in their actual report. So pre and post-test intervention audits were carried out as a part of this quality enhancement initiative to assess and enhance the knowledge levels of nurses related to the prevention of pressure ulcers. The minor project included 10 participants, so these are small numbers, particularly compared to the other one that had 64. And I think most people are going to have small numbers with all the projects. That's all. Anyway, so this minor project included 10 participants, 5 being registered nurses and 5 being assistant in nursing. This design was used to evaluate changes in knowledge before and after targeted interventions, providing a comprehensive framework for evaluation. The pre-test questionnaires were administered before an educational intervention was delivered, and then the post-test questionnaires were administered following the intervention to evaluate the improvement. Pre-intervention audit was conducted on 10 nurses, and the level of knowledge was assessed using that pressure ulcer knowledge assessment tool, the PUCAT questionnaire. A structured questionnaire with multi-choice questions that covered etiology, classification, risk assessment, nutrition, and preventative strategies of pressure ulcers were provided to nurses. So the pre-intervention audit was carried out in, put the date, and according to the pre-test questionnaire audit, nurses had several misconceptions regarding the etiology of pressure ulcers. Half of the nurses, 50%, believed that moisture was the cause of pressure ulcers, whereas 10% of them thought that malnutrition was the cause. While 20% of nurses reported they were not aware of the underlying cause, and unexpectedly, only 20% of nurses correctly recognised the major cause of pressure ulcers as a lack of oxygen supply to skin tissues. The audit additionally identified that more than half, so 60% of the nurses, had the false belief that the hip, shoulder, and heels are the areas where pressure ulcers are more prone to form when a person is in a sitting position. Furthermore, 10% of the nurses believed that the knee, ankle, and hip would be the most common sites for pressure ulcers. Only 30% of the nurses correctly identified the most common areas for pressure ulcer development in sitting positions, which were below the elbow, pelvic area, and heel. The pre-test questionnaire identified knowledge gaps among nurses regarding the risk evaluation for the development of pressure ulcers. Only 30% of nurses correctly answered that patients with a history of pressure ulcers are more susceptible to acquire new pressure ulcers, whereas 2/4, 50% of the nurses thought that placing absorbing pads under the patient was the best method to lower the risk of developing the ulcers. Additionally, when asked which pressure ulcer prevention approach will be best for bedridden patients who are immobile, most nurses, 60%, selected a pressure redistributing foam mattress as the prevention measure. However, only 20% of nurses correctly identified an alternative pressure area mattress as the most effective intervention. And then they had all their tables in the appendix. So they then go on to describe the results for the post-intervention. So this person has done it, they've presented all their pre and they've presented all their post, whereas the previous example, they've obviously done it together. So you could see that change. My preference is to do it where you can see the change, but you can do it in whatever way works for your project or data. So the post-intervention audit, on the other hand, utilised the same questionnaire and was completed in September. The post-audit results demonstrated that nurses' understanding of the etiology of pressure ulcers had significantly improved after the educational intervention. More than half of the nurses correctly identified that oxygen deprivation causes pressure ulcers, compared to 20% during their pre-intervention phase. The comparison to just 30% of nurses, in comparison, who responded correctly during the pre-intervention period, 100% of nurses later correctly recognised the pelvic area, elbow, and heel as the most likely areas for pressure ulcers developing in a sitting position. The majority of nurses, 80%, accurately answered that optimising nutrients lowers the possibility of pressure ulcers in the post-test questionnaire, despite the fact. So what they're saying is, but it was 10% of nurses correctly answered the pre-test questionnaire. In the post-intervention audit, 90% of nurses accurately identified the implementation of an alternating pressure air mattress as the most effective approach for preventing pressure ulcers in bedridden patients, and that was in Appendix 3. So then they sort of followed up with some concluding paragraphs. So this demonstrates a significant improvement in knowledge regarding the most effective preventative measures in cases where pre-positioning is not possible. To evaluate the effectiveness of post-intervention audits, the extracted data were analysed with the total number of nurses being 100%. The post-intervention findings demonstrated a notable improvement in knowledge of nurses related to pressure ulcer etiology, classification, risk assessment, and preventative strategies. And the nurses were aware of pressure ulcers. The nurses' awareness of pressure ulcers was improved by the educational intervention, which additionally led to a decrease in misconceptions related to pressure ulcers and improved patient care. So their appendices, this is how they presented there. So they did all of their pre-test results in one table. And then they did all of their post-intervention test results in another table, in a separate table in Appendix 3. They also did some bar charts, so they were responses to those questions related to the 5 different areas, so etiology, classification, risk assessment, nutrition, and preventative measures. So just showing the changes, showing the frequency of the responses in the pre-test. And then they also did the same bar chart in the post-test, showing those changes over time, changes post. I would recommend, I prefer the first way to set it out, where you can see the comparison side by side. That's how I would do it. Does anyone have any questions about that one? About those two?
Gemma, I have a question. Apologies, my camera's decided it doesn't work anymore. I just wanted to ask, are you expecting that we do a bit of copy and paste from our original proposal in reference to the aim? Like, are we just pretty much transcribing that over into this summary and we won't lose marks if it is a copy of our own self-plagiarism? Yeah, okay, perfect.
No, so and so in the report as well, we've got it. Let me find it. So there's a template for this one as well. So this is a template for your final report. So a lot of what will go in here, this executive summary, you can take from your proposal. So your aim, your methods will be from your proposal. Your background will need to be much shorter because this is only 200 words. So it'll be an abridged or edited down background. Your main findings will be a brief summary, like essentially tell me about the change, and then your conclusion. So that's mostly where your proposal stuff, you can just bring that over into here, into the executive summary. And then the new main things are the main findings and your discussion. This will all be new. What you'll be able to, you can't do until you finish the project because you need the results. But this is what you'd be filling in that would be new. And you can take some of the background from your proposal as well. You may need to expand on it, or not. And then you can put all your appendices down here. So your project timeline and then your pre and post collection tools.
Thank you. Can I ask, I haven't seen that uploaded yet. Is that on the e-learning or is that not there as yet?
It should be, but I'll check after.
Thank you.
Thought I put it in the resources, but let me double check that it's on there. I'll put that there.
Yeah, Gemma, I had the same thing. I'm just looking at now under assessment 3, the project final output, it says not available. So you
Oh,
can't
sorry. Okay, I've
expand
not
it.
made it free yet, available yet. Okay, I'll open that up for you
Yeah,
when we get
thank you.
offline.
Thank you.
Yep. Okay. Are there any other questions? Just saw Erin. I don't know if she might have gone already. Yeah.
Gemma.
Yeah.
Thanks. Sorry, I had a question. Just in my project, I did a barrier assessment before I went ahead and looked at the intervention, and I'm just trying to figure out whether I put the results of the barrier assessment in the results or in the background to kind of justify why I need to do the project.
I put it in the background.
Yep.
Yeah.
Easy.
Yes.
Cool. Thanks.
Yep. Anyone else? The other thing I was going to show you. Oh, actually, do you want to have a break? I just realized it's 9:30. Want to have a quick break?
I think that would be great. When did you
Okay.
want us to come back?
Thank
Yeah.
you.
It's a lot of talking. Do you want to? I've lost my phone. Jen, is 10 minutes too much?
No,
Or is
that's
that
fine.
okay?
No,
That's fine?
that's
Okay,
fine.
10 minutes. So
Sounds
I've got
good.
9:35. So if you come back at 9:45.
Brilliant. Thank you. Thanks.
Thank you.
Mhm. Oh, this up. Does anyone have any questions? Arthur, you've managed to get on. Arthur, working now. Okay. I've only got a little bit of content left, so we'll likely finish early, or we can stop and go through any questions. Just to make sure I've covered everything for you, I thought I'd also go through thematic analysis because quite a few people talked about either doing interviews or focus groups and having qualitative data and theming that kind of thing. And you talked about thematic analysis in your proposals. So I just wanted to touch on that process. If you end up with qualitative data as a part of your project, then what I recommend is that you use the Braun and Clark thematic analysis, which is the most common one used. There's 6 steps to it. So familiarizing yourself with the data, so reading it over and over and over again, generating initial codes, generating themes, reviewing those themes, defining and naming themes, and then writing up. So that's the Braun and Clark process. And there are some references that you can use. So you need to reference the process that you've used in your report. And I just have this YouTube clip on how to do thematic analysis.
Empower your students to be more authentic, impactful writers with Grammarly's comprehensive AI writing assistance.
You've come across thematic analysis.
Am I going to check?
And
I can't see you all again.
Qualitative research method is all about.
Someone just
No
let me know
problem.
if you
In
can.
this video, you will learn
hear
the
this.
6 steps of thematic analysis
Yes, we
according
can hear it.
to Braun and Clark.
Thank you.
The different types of thematic analysis you can do, the difference between thematic analysis and qualitative content analysis, and the types of research projects for which thematic analysis is particularly well suited. And now, without further ado, welcome to Scribe. Thematic analysis is one of the most popular qualitative research methods out there. Since Braun and Clark published their paper using thematic analysis in psychology in 2006, it has been cited over 150,000 times. Therefore, the method has gained recognition far beyond the realms of psychology and is used across various disciplines. The reasons for the popularity of thematic analysis are manifold. Unlike grounded theory, it represents a specific method rather than a methodological approach. This means that there are concrete steps for its execution that have been clearly and explicitly defined. Moreover, thematic analysis still offers a certain flexibility, which is essential for qualitative approaches. The method has evolved very little since 2006, meaning the guidelines by Braun and Clark are still highly relevant. However, since then, the duo has distinguished between 3 different kinds of thematic analysis. This differentiation arose because the method was sometimes interpreted in ways different from what they originally intended. The 3 types are as follows. Reflexive thematic analysis. This is the method as Braun and Clark envisioned it. It's based on a constructivist mindset, meaning subjective interpretations of the qualitative data are at the forefront. Positivist thematic analysis. In this variant, researchers compute a reliability measure to check for agreement among them or check the frequency of categories. This version of thematic analysis follows more of a positivist mindset and isn't quite what the 2 authors originally had in mind. Thematic analysis with a codebook. This 3rd variant is neither one extreme nor the other. It involves working with a codebook, which can contain predefined categories, but can also be expanded spontaneously. Now, what is a theme? A theme is either a summary of the content or a central concept that encapsulates the meaning of similar contents. Themes cannot be discovered or found within the content. They have to be generated by you as the researcher. So never write, I identified 5 themes, but instead say, I developed 5 themes. What now follows are the 6 steps of reflexive thematic analysis as proposed by Brown and Clark. Step 1. Familiarize yourself with the data. First, transcribe your data if you have it only available in audio or video format. Then, read the entire dataset twice, from start to finish. This gives you a good overview of all your material. It's better than starting to evaluate a transcript without knowing the rest. Try to fully immerse yourself in the situation described in the transcripts. However, always maintain an analytical perspective. Take notes as you read. You can also take notes right after conducting an interview or while visiting a company on site, if that's your research context. All your notes are for your personal use. You don't need to share them later. However, they will assist you in the evaluation later on. In your notes, jot down your initial reactions. These can be analytical or purely intuitive. Step 2. Generate initial codes. Now it's time to start coding. The codes that emerge at this stage are not yet themes, but categories. What are categories? Try to code all your data according to the same schema. That is, find categories on a consistently similar level of abstraction. An example of a category would be democratic decision-making within the team. Another category on the same level could be open discussion about the integration of new technologies. 2 categories that are not on the same level might be hierarchy, which is too abstract at this point, and weekly meetings where hiring decisions are made, which is not abstract enough. With the categories, you can certainly venture a preliminary interpretation, like democratic decision-making. This exact phrase wasn't really in the data, it's something that you interpreted. But what's the purpose of the categories? They reduce the volume of your data and group your analytical units. What's essential for thematic analysis, as per Brown and Clark, is that you don't code everything. Instead, you should only form categories that are relevant to your research question. In the data, you will find many sections that just aren't interesting and won't help answer your question. You don't need to code these sections. The naming of your categories should be chosen such that they precisely describe what's relevant to your question. A category doesn't have to consist of just one word. It can be a bit longer, like 3 to 6 words. How to code? You can either work digitally with software like Mvivo or use pen and sticky notes. I'm more of a software person, but everyone has their own preferences. Even while coding, you can and should continue to take notes that you can use later on. Step 3. Generate the first themes. The reflexive thematic analysis by Brown and Clark operates inductively. Your themes should arise exclusively based on your data, and at this point, based on your categories. Now for that, group the categories and codes that you have. Which ones are thematically related? This will lead to clusters of categories. Each cluster will then become a theme. Here you can also work with mind maps and visually develop the clusters. It's also possible that within a larger cluster, you have smaller clusters or sub-themes. However, try not to make it too complicated. In the end, having 3 to 6 main themes is a good amount to work with. The biggest mistake in coding and also in generating themes is the use of so-called buckets. A classic bucket includes categories or themes like advantages, disadvantages, barriers, or challenges. It's crucial to steer clear of these. Step 4. Review your themes. Once you've finalized all the themes, create a final mind map featuring all the themes, potential sub-themes, and categories. Check if everything forms a coherent overall picture and accurately reflects the content of the data. Ask yourself the following questions for each theme. Is this more than just a category? Does this theme encapsulate multiple categories? How does the theme relate to the research question? Are there overlaps between themes? Is there sufficient data supporting the theme? And is the theme too broad or too specific? If you encounter issues with these questions, such as overlapping themes, take a step back and rephrase the themes or rearrange the structure. Thematic analysis by Brown and Clark isn't a linear process. You can always move forward and backward as needed. Now, before we get to step 5, please consider to give this video a like and subscribe to the channel if you want to see more of this type of content. Step 5. Define and name your themes. Now write a detailed description for each theme, comprising 5 to 6 sentences. Also, finalize the specific designation for each theme. If you encounter issues while describing or naming, it typically indicates that the theme isn't distinct enough yet.
Monday CRM has the best AI features in the game,
especially in sales.
hands down.
So for me, email composition works like
In such cases, revert a step or two and reconsider. Step 6. Write down your findings. The final step for your thematic analysis is drafting your report. In most cases, this will be an academic paper. Now you will integrate your findings with existing literature and align the motivation, research question, results, and discussion. In your methodology section, ensure to cite Brown and Clark and explain how you approached your thematic analysis. In the results section, introduce all the themes at a glance and then delve deeper into each specific theme. Provide quotes from your data that represent each theme. Certainly, let the quotes speak for themselves. They can even be a bit lengthy. However, simply stringing together quotes isn't sufficient. Between them, you must jot down your interpretation and establish the connection between the data and the theme. Now, what's the difference between Brown and Clark's thematic analysis and qualitative content analysis? Answering this question is not that straightforward. The approach suggested by Brown and Clark is simply their perspective on systematically analyzing qualitative data. With qualitative content analysis, there are different variations too, for example, by the German social scientists Philipp Mayring or Udo Kuckertz. A content analysis would probably be more suited if you have a big qualitative data set and would like to count your categories, or if you want to develop a code book for other researchers to use. The procedures of thematic analysis and inductive content analysis are quite similar and differ by maybe 1 or 2 steps and their respective labels. When selecting your method, consider the target audience for your research. For more interpretive research and an English-speaking audience, choose thematic analysis. For a more structured approach and some quantification of your qualitative data, choose content analysis.
Does anyone have any questions about that? Sorry, I can't see again. Does anyone have any questions? That was long-winded, like that's what you would do for if you're doing a qualitative research study, but it just shows you the steps you'd need to follow if you've got some interview data. That's the proper process.
Hey Gemma, sorry,
Yeah.
it's Trin. Can I just
Hi.
quickly ask a question?
Yeah.
I've got I'm doing a survey and I've got open-ended questions in my survey, and I've written that I was going to do qualitative analysis on that. So it's not focus groups or interviews, it's just survey.
Yeah.
Is that still appropriate, like to follow those steps and do
Yeah.
that?
yeah, a very abridged version because you're
Yes.
in your responses, you'll likely have,
It's going to be quite short and
short. Yeah, yeah.
yeah.
So it would be really just picking out, yeah, what are the key sort of codes or points that people are making, and how can you summarize that? How can you sort of group it and summarize it?
Yeah. And then
Yeah.
would you still suggest putting quotes? Yeah,
No, you don't. Sorry, you don't. This really was, that video really is if you're doing qualitative research like this.
Okay.
It was just to make sure you know that there's a whole process behind it. You don't have to do that um in your report. You could if you have an appendix at the end and you wanted to include that, the open-ended question. Yeah, you know, if you wanted to provide some sort of evidence of it, then yeah, I'm very happy to read it in there. I think it is interesting, but you don't have to include quotes within the report.
Okay, perfect. Thank you.
Um, the next thing I was just going to say, I'm going to put some papers online just to show you what you could do if you wanted to publish this at the end, or if you want to develop it further to try and publish it, just giving you some examples. So I'll put some example published papers online on Moodle afterwards. But I was just going to show you, this is one of them. So it was a QI project where they looked at evaluation of an intervention targeting follow-up appointment scheduling, emergency department referral to ophthalmology clinics. So it's a QI project. They used the PDSA cycle thing, and this is how they set it out. So you can just, again, you don't need to do all of this in your report. I'm just showing you. It might give you some ideas on how you want to report things, or you could do a diagram or things like that if you wanted to, or you can use it to look at what you'd need to do to publish your paper, your project. This was another published paper using the QI project and PDSA method. So decreasing stroke code to CT time in patient presenting with stroke symptoms. And so that's how they reported those ones. And then there's another QI project where they were looking at the implementation of early palliative care referral in lung cancer. Again, so they're just some resources if you wanted to look at, get some ideas around how you could report your stuff, your findings. So now I don't have any more content for you per se. So if you've got any questions, the other thing I can show you how to do the descriptive statistics on Excel if you want me to do that.
Yes, please. And I think there's also a question in the text, if there's any examples of the assessment too as well.
Oh yeah. Yes, sorry.
The video pitch.
So I don't have an example of assessment 2 because I can't anonymize, because it's just someone speaking to us. I can't anonymize that. But it's really, there's no trick to it. It's just you talking to me about your project. And essentially you're talking through your proposal. But talk as though you're talking to the general public. Yeah. Sorry, I'll show you. So I put this Excel spreadsheet on Moodle last week, and I had the say for example, we're looking at a project of falls, and so I had some pre-falls in there, and I also put some post-falls in, just completely made up. If when you put your numbers in here, it will calculate your mean, median, and mode and your standard deviation as well. It'll do that automatically for you. But the other thing that you can do, if you get the little plugin thing, data analysis, you'll sort of spin through the thing, the options, and go to descriptive statistics. And then your input range, what that means, whoops. Your input range is it means what numbers do you want it to look at? What do you want it to calculate? So I want to do descriptive. Sorry, should have just left it. I want to look at descriptive statistics of all of my pre-falls, and then the output range. You can either add it into a new sheet, so it would open up a new sheet down here. But I put an output range, and I want to say I want to put it there. That you're just telling the system where to put the results. And I want summary statistics. So these things won't be ticked when you do it. And I want confidence levels for the mean. And then you go, oh, this is not working. Let me fix it. Right. So my input range, there. And then my output range, I want that to go there. And I want summary statistics and I want confidence levels. So of this data here, my pre-data, it's telling me, I mean, we knew from up here anyway, but the mean is there's been 2.6 falls. The standard error is 0.8, median is 3, mode is 4, and your standard deviation is 1.9. So these are essentially all I would need to see in your assignments. And then there's just a selection of other things we can look at. These things here, kurtosis and skewness, you don't need to know about these unless you're doing a research project and going on to do further analysis. But these tell you about like the distribution of the data, like the skewness of the graph, the bell curve, the histogram. Gives us the range. And minimum was 0. One person had 0 falls, and the maximum number of falls was 5, 16, and then there were 6. The count is 6. There were 6 people. And the 95% confidence level was 0.2. So you add and minus that onto the mean to get your confidence level range. And then you can do the same. You want to look at descriptive statistics for the post data. And that, and I want to this time want my output range to be there. Okay. And so now the mean number of falls is reduced in the post group to 1.3. Standard error is 0.4, median 1, mode 1, standard deviation 1.3. So is that okay? This data analysis package does do t-tests and things. So some people had mentioned in their assignments they'll be doing t-tests, which I'm very welcome to it. You can do that. It is interesting. And so you can do this through this data analysis package as well. You don't need to have a special data analysis package like SPSS or other things. And it's the same way. So we're putting those in for the range. Which was that one. Don't know if it'll let me. I don't know if it's going to make me put in a hypothesized range. Yeah, no. I'm not gonna do that. Zero. Oh, it's making me. Anyway. How's that? Any questions? And you can do graphs in Excel and everything as well. You can do all those. Open. But that's all I have. So it's really up to you guys if you've got any questions. I know some people have sent me emails about their assignments, and I am getting to it. I will respond by today to those people who've sent me an email.
Hi, Gemma.
Hey.
Hey, just with transporting that Excel results into sort of the document that we're writing up on, I haven't done that before. Would a screenshot be okay, or do we need to actually sort of cut and
you can do
paste? Yeah.
You can do a screenshot, or you can do either. So if it works well for you to do the screenshot, just do that. So when I'm writing papers and things, I usually just cut and paste into Word and develop my own table because it's just too hard to deal with Excel in that way. So there is a bit of manual processing when you do, full on, do a full data analysis for research.
Thanks.
Yeah.
And I had one more question around sort of how much you want to read in our report, because my barrier assessment is a 14-question survey. And I listed those questions in the appendix of the first assignment. I'm just thinking that'll be a lot to read. Is it okay if I just do like a summary paragraph of that rather than listing every answer to every question?
Yeah, you can just do a summary paragraph. And if for some reason you think it's really necessary for me to know what was in that, you can just put like in parentheses, just write that like refer to proposal assessment.
Yeah, cool. Thanks.
Yeah.
Thank you.
Anyone else? Tara, I saw you had trouble with your audio getting in. You got in the end?
Yeah, I was waiting around I didn't log on until like 8:45, and then I waited for about 15 minutes and I had to go to the ward for a meeting.
I'm so sorry.
No, that's fine. I was late and I thought because I'm juggling this between acute ward duties, so I'm kind of coming back and forth to my office. So I'll watch the video, I'll watch the recording and kind of catch up on the descriptive stats because that's what I'm keen to know a little bit more about for the report. Yeah. So that's cool. Thank you.
That's all right. Sorry, I can't see the waiting room once I share the screen. So
No,
you
that's
need
good.
two
That's
people facilitating these things.
Yes. It's not ideal, is it? No.
No.
Well, thanks for that.
You're very welcome. I hope it's helpful and I hope your projects are going well and that, so easy. Smooth sailing. All right, I'll let you go if no one has any questions. But thank you.
Thanks so much, Gemma. Appreciate it.
Yep. Thanks,
Very welcome.
Gemma.
Thank you.
I will.
Bye.
Oh, see you in another 2 weeks. So your assignment's due in 2 weeks and we'll have the last workshop then.
Great.
Wonderful. Thank you.
See you. Bye.
Hey guys. Bye.
Thanks, Gemma. Thanks, everyone.
Thank you.